Hello and welcome. We are just getting started here. I want to thank you. I want to welcome my Facebook family, and I want to thank all those folks for participating. I really do appreciate the fact that uh, um, well, we are being listened to. I know the headline says community unity, but that is too. But this is Education is the Best Medicine. We are here at Believe Radio, and I want to thank all the staff, Curtis especially, for helping me get the show started. Um, and I want to wish Miss Howard a great graduation. She's graduating from Laney College with her AA, and real worked hard, real deserved, and I want to just put her out. And again, thank all the staff for allowing us to be here today. I wanted to kind of start by saying um, had some concerns, and so I try to really kind of address the concerns in terms of not only the concerns of the community, but the concerns of in terms of health and healthcare access. I think that's a real issue now, and we have to be asking about the quality of the care that we receive, and it's reflective of our health. I think that uh, we have to kind of understand some concerns in the community. And we had originally started off talking about, again, this is almost the end of May, and this May is the mental health month, and as well as talking about issues in terms of access. And we had mentioned, one of our major concerns was suicide, and I wanted people again to get the number for at the CDC for it's a National Suicide Prevention Hotline. It's 800-273-8255. And also, I want to say that again, all these concerns are purely opinional, and if there's really concerns, to take it up with your healthcare or mental health care provider, and in terms of medicines and changes and that kind of thing. But I wanted to kind of uh, have that continued discussion around mental health. And we talked about last week in relationship to public health. So, and what we now understand is that good mental health is not only good, it's good public policy. Again, and we think that if these issues are of a public health nature, then we need to be kind of data driven, and in a scientific and a systematic fashion. That's what public health should do. It's really under the study of epidemiology, and somehow around the late 1800s, there was a separation in general medicine from public health concepts. And so in reality, we had two, and that's why you see on the major campuses, there's a public health school and there's a school of medicine. And at one point in time, they were synonymous. So the discussion is that a number of our healthcare providers have missed the public health discussion, and in regards to prevention, and that has was unfairly so, or fairly so, placed at the foot of primary care, which up until the last couple of years, which really was a stepchild to a lot of the uh, healthcare systems. And what I mean by that is that primary care providers had to work harder to get referrals, to get assist care that was uh, seamless. So that's what we did. That's what we had to do. That's what I continue to do. So to understand that one of the problems with the healthcare model is it being disjointed. And one of the real common issues in people of color is that they don't like to travel around to get their health care. They want everything in one place, like going to the supermarket. You want everything in one place. So you don't have to travel because it costs you to get there, it costs you to leave, it costs you to take your babies with you, all that kind of thing. So it's one of the things that we kind of have to look at. Um, and so I want folks to kind of understand that, once these models were separated, we just start, and rightly so, two systems of care. One group of people thinking about just the you know, cure the cold, fix the fracture, treat the heart attack. And one group thinking about, well, how do you prevent this? How do you, is it food, clothing, and shelter? Is it lack of, is it food islands? Is it stress and racism and structural and institutional racism and intergenerational trauma that kind of feeds those healthcare models and kind of discussions about, whether one plant is watered and grows and one plant dies. Um, uh, and that's an analogy of a black woman. Uh, Her name is uh, Dr. Carmen Jones, and Dr. Carmen Jones was significant because she again discussed it, was able to. She did a sentinel paper called "Naming Racism," and in this discussion of naming racism, the good doctor, who's quite brilliant and still practicing, still working, still providing foundational care. But at the time that she did it, it was really really unique, and to be provided a grant from the NIH to study this question of racism was really sentinel. Um, she was quite ahead of her time. And again, back to women and health and um, um, uh, Dr. Carmen Phyllis Jones, and this is under the issue of social determinants. Again, social determinants, the things of food, clothing, and shelter, and she named in her sentinel paper letters of institutional, personally mediated, and internalized racism. And she defined institutionalized racism as differential access to goods, services, and opportunities of society by race, and codified in societal structures, processes, and values. So the reason why I'm bringing this up, because we're having a discussion now about white replacement theory. And I think it's kind of really important because it's fueling a lot of the angst, is the fact that um, uh, white folks think they're going to be replaced. I don't know by whom, I don't know why, but that is the prevailing fear, such as the fear that drove a young 18-year-old man to go into a supermarket in New York and kill 10 black folks just because they were black. And it again kind of recodifies that we are not safe, that um, anyone can extract harm upon us in our community, and they are now have to be called to order. But he was doing a whole bunch of stuff way before then. So I just wanted to kind of mention that as a discussion because, you know, we're looking at, again, back to our mental health, and not only our mental health, but our physical health. Um, it's interesting that that one supermarket where this atrocity was carried out is the only supermarket that they had in the area that served African Americans with quality products, and it was safe, and so they thought. Um, and I think that this is the state of why we have to talk about these things and kind of understand them, and kind of make a discussion about why people are thinking the way they're thinking, and if it's a thinking that has a basis for it, I think we need to listen and understand how we can be a little bit better. But if it's a thinking that says that here's the definition of white, what is called great replacement. It's a supposition of a system that or ideals intended to explain something, especially one based on general principles. um, and uh, it it is, in short, The Great Replacement is a conspiracy theory that states that non-white individuals are being brought into the United States and other Western countries to replace white voters to achieve a political agenda. It is often touted by anti-immigration groups, white supremacists, and others, according to the National Immigration Forum. So the reason why I'm bringing it up because this affects our health, the state of being in perpetual fear, in perpetual trauma, and in perpetual from either uh, enemies, foreign or domestic, to be attacked in your own community and murdered in your own community, just because you're who you are. And so I think that's really un-American. I think it's very sad that more of our political leadership is not calling this out for what it is. We have a code of silence that verifies and allows this behavior to take place, and it's just not right. I mean, it is just not right. And um, and because it's called the Great Replacement theory, I want to define theory. It's the supposition, it's the thought or a system of ideas intended to explain something, especially one based on general principles, independent of the thing to be explained. It's a set of principles which, in the practice of activities based. Example, the theory of education. And it's an idea used to account for a situation or to justify a course of action. So in reality, it was just a theory. This is just a theory. The white replacement is just a theory. There's no data to support it. There's no, you know, secret about this issue. Now, I will grant you that people of color are going to be the dominant number of people in the next 20 to 25 years, but they don't control the court system, they don't control the economic system, they don't control the legal system, they don't control the education system. So, they say that um, uh, you got to have the power in order to do those things. So, in terms of replacement, I don't think that's a valid reason to go and murder 10 black folks, but that's me. Um, and it got us back to this discussion again around mental health or mental illness or mental wealth. And again, we define mental health as what is the full meaning of mental health? Mental health refers to the cognitive, behavioral, and emotional well-being. It's all about how people think, feel, and behave. People sometimes use the term mental health to mean the absence of a mental disorder. Mental health can affect daily living, relationships, and physical health. And I think that that's what we should strive for in anyone in every community that we are functioning in. Um, it seems again, the schism between public health and clinical medicine is the biggest difference. This is why um, Mr. Patrick Remington, yeah, he was doing a discussion on TED Talk. And I guess it was the last couple of years, and 2017 to be exact. And he asked that question about and wanted to discuss the schism between public health and clinical medicine. He said the biggest difference between public health and medicine is the public health deals with the health from the perspective of populations, while medicine deals with the health from the perspective of the individual. In medicine, the patient is the individual person. In the public health, the patient is the entire community. Wouldn't that be great? That And when we looked at an individual in the healthcare system, we looked at the community. And so that visionary look would say that how do I want this person to function in this community? Do I want him to have food, clothing, shelter? Do I want him to be absent of disease, right? In terms of the public health discussion around in Almata, it's not just the absence of disease, right? Health isn't just the absence of disease. Um, it's is it a moral, social, political obligation? I think it is. It has to be. It's a moral imperative. It's a public health issue. And So I think that understanding that these two diametrically opposed issues, and just be clear too, it was about money. The separation of public health and um, clinical medicine, its education, the profession was about money. And so that's should never drive discussions about health. It's the last thing to do. The discussion, if you do a good job in terms of a public health model and function and prevent that individual from encompassing more issues in terms of hospitalization, in terms of trauma, the cost of poorly controlled diabetes, the cost of poorly controlled hypertension, to the point that we're talking about pre-diabetes and pre-hypertension, the cost of addressing the mental health issues of a communities, whether it be anxiety or depression or schizophrenia or ADHD or trauma informed care that speaks to that issue, not tries to cover it up. You know, it's a level of sensitivity that I think that we have to have. Um, and the three core functions of public health. Um, Monitor health status to identify community health problems, diagnose and investigate health problems and health hazards to the community, inform, educate, empower people about health issues. My original search is public health public, or does the society feel we should be just happy to have the services that we have? And I think for a long time, that's what laid the uh, chasm open in terms of COVID. And by the way, COVID's not over yet. The cases are rising in California. The current data is looking at the Omicron variant, and so SARS-CoV, the Omicron, and now the variants are, I think it's AB1 and AB2. Well, AB1 is kind of like what's going on in the community now. And so I always ask people to look at Europe, look at particularly the Asian community, and uh, if you see that rate of infection, although there's some discussion about whether that type of escalation in us being exposed to the viruses is really warranted, because in China, particularly, they used a weaker vaccine and they didn't immunize everyone. And my understanding is the elderly Asians did not want to do the vaccine, so there's a whole nexus of individuals that are um, being exposed that weren't before. And again, the question I always ask, and I continue to ask this: what's going on with the vaccination status of kids babies to 4? There's been no mention of them. I think that we need to understand that we wouldn't want those kids exposed, because what they're just recently in a Medscape article, these young kids are now developing hepatitis. I think about 88 over the world, and they're looking at the COVID virus having mutated to inflame adenoviruses to inflame the kids' livers. And again, it makes sense because babies, those kids are still immune compromised, and a lot of them haven't had their shots in general. So they're more compromised in a more hostile environment. So I think that we need to kind of rethink that. That's why I'm still wearing my mask. I'm not worried about me. I'm worried about that 0 to 4 year old and her mother walking that child past me. And I've been vaccinated. So I think that people need to kind of really kind of reassess, and because the masks are cheap, COVID is expensive, and I'm concerned about those kids that, although it may not be a large population, they'll get COVID and they'll have, cognitive dysfunction, fatigue syndromes. They don't need that. Who wants that? Who wants that for their kid, their baby, you know? So I think that we need to kind of rethink that. Um, And I think, and if you could layer this perfect world, those things would take place. But this is not a perfect world. And again, the issues around structural and institutional racism and quality access and fair access and humane and empathetic access are still far, far away. And I always say now, and I have to say it now, because I've been practicing 30, almost 35 years, so I can say that as a PA. If you don't like me, if you don't think I have worth, if you don't think I'm a rarity, if you don't think um, um, I deserve care, then you don't give me good care. And I witness this by saying that the numbers tend to reflect um, that um, we don't do well. We don't do well not because we can't do well, because it's not set up in that way. And uh, I I recently, well, a number of years back, this is a recent study, a study from uh, Kaiser Permanente, and it was a young health analyst. Uh, uh, just a second. Her name was Kayla Lewis. She was senior policy analyst at Kaiser, and this was around. Can't date. And the paper was entitled uh, e- Race, Ethnicity in Healthcare." So, and it was the general numbers were that, what you saw in death ratios, and this is in the year 2000, that African Americans died at a high rate, followed by Native Americans, followed by whites, followed by Latino, and that may have changed. But that's how it looked. And in terms of infant mortality, it's interesting. Again, this is 2000. This is why they are now launching the study around um, women in California and infant mortality rates, because they've always been dismal. It's one of the very few, and I'm not really a stat data guy, but those are one of the few things I always remember in discussing women's health uh, uh, in my PA school, was that women of color suffered more stillborn and more deaths during delivery. And then you have to think about, it's just not them, it's that public health question about, did they have the access, did they have the prenatal visits, did they have the nutrition, were they able to take time off from work, were they having to work and carry this child, which a lot of women of color do because they can't afford not to work. And I think now what's really interesting to me is that group of women that I watched have those problems were didn't have insurance. The group of women now have insurance, and we're still having the same outcomes. Um, it was the African Americans had at that time, for every 1,000 births, they had 15 deaths. There was a lack of insurance for African Americans and Latino women. Something like 18% uninsured, 29% uninsured. And again, what does that mean? That means you don't have access to the system. You can't get in. You can't see. You can't develop a relationship with someone that's going to carry your baby to term. You're always seeing somebody different. You always see somebody doesn't know anything, or maybe racist, or doesn't want to see you, or doesn't even like doing the care. You know, and I think at this point you have to know what you like to do and what you don't like to do. So again, part of the Great Resignation, right? Um, do I want to take care of a community anymore when I'm afraid of getting COVID or being exposed, or my children being exposed? Changes the dynamic. Changes the dynamic. Um, and and what we saw then was that with the percentage of with no healthcare visits in the past year related to their insurance. Um, Interesting. It was 32%, and this is with under 100% on the poverty line. And we saw 19% for whites, 32% for Latinos, and 18% for African Americans. And gee, uh, disparities in uh, specialty care for again for Medicare patients. Um, and this is around between 1994 and 1995. The data is there; it exists. Less likely to get procedures, less likely to be referred. This is the whole issue with women and heart disease. Well, if I don't think you can have heart disease, then why would I want to refer you for advanced testing? You have to think about it first and know that, understand it. That's a high group, women of color. Particularly if they have hypertension or diabetes, or if they had a family history, or have poorly controlled blood pressure, they're high risk easily. But yeah, think about it and say, is this person worth saving? Well, I tell people from an economic standpoint, it's easier to see a specialty appointment um, to the cardiologist in simple follow up manner as opposed to that person being rushed to the ER with a massive heart attack, having had to be resuscitated because of VTAC. You know, what is that in terms of cost, and do we save that person? Prevention is worth a pound of cure. The whole issue around public health, um, and I think that the point of this is that we have to be more proactive as opposed to being reactive, and that um, I believe that if we're not, then we doom ourselves to a level of mediocrity. Um, and I want to again thank Believe Radio and the Eyes of the Conscious Soul. Uh, um, Please tune in and check out. We're trying to download, so I'm running this on Facebook now. Hopefully, it works. Okay. Uh, and by the way, Facebook took me off of Facebook. They had to review the site. I don't know what that was about. I was just running these shows here, so I didn't know what the issue was. But it gets to this discussion about how things are being done. Like they use a lot of these what they call our bots, and basically they go and they assess keywords in a particular discussion to see if it may not meet their criteria, or would they think this was a bot and the person that's creating this dialogue is not real. So I had to take a picture and all that kind of stuff. That was kind of weird, really, really kind of wild, but hey, it is what it is. And I think part of this discussion for me has been trying to redefine what is the public health issue. Well, it's poverty, it's racism, it's sexism, and it's a challenge to create a better working model for examining our health and why we're not doing a good job with African Americans. And we're still number one in heart disease and cancer. We have poor outcomes. It relates to mental health. 25% incarcerated, 25% homeless. And if you're in LA or you're in the Bay, as I was in if you're in the Bay Area, you die of a drug overdose. And I was, again, I mentioned this in the last show, but I thought it was really important as one of the primary public health issues was another TED Talk by Dr. Lisa Rankin. And when she was asked and thought about the number one public health issue, she mentioned that we are a tribal people and that we work in groups and we work as a common group to the whole. In other words, it's not the individual, it's the group. And they found those particular tribes that people lived longer than lonely people. And so and so a lot of the studies show that it's not heart disease, cancer, infection, anxiety, and 1 in 5 Americans have committed suicide. That's why I give out that number. Please, I'm going to repeat it again. But 1 in 5 Americans are lonely. The feeling of being separate and others and to dissociate from the family of humankind. And think about that, because what's going on now in the world? We have a lot of people lonely. We have a lot of people that are disassociated from friends and family, myself included. And so you have to kind of work on those kinds of things, because in reality, we still are a community of people. And so when I talk about public health, not so the public health issue is the individual, because how we treat the individual is how the community will reflect it. And and I think that this is why this whole discussion around mental health, because it's a public health issue, and and the discussion around self care, is kind of like overworked as a one of the in one of the talks I reviewed on public health. It says that there's 50 million self help tags that if you put it into the search engine, you get 50 million. But what does that mean? You know, uh, the catchy phrases, or new diets or anything, because really the discussion is, if people are lonely, how do you communicate with that loneliness? um and and again, mental health, it defines coping with stress, maintaining meaningful relationships, and management of things, and discussed it also discussed mental health and stresses in the community. One of our biggest issues, and I'll mention it now, in terms of our mental health in a number of communities, and this has nothing to do with race, age, sex, gender, classification, stigma. Stigma plays a major role. And 22% of Americans did not receive and the needed care, and it was reflective in the culture. For example, 86% of providers are white and 5% are black. And it speaks to a lack of access to providers. And what I would say too is that it's not that a white provider can't take care of a person of color. Other things need to be discussed sometimes. And if that provider is really discuss those things, then he'll be or she'll be a good provider. I'm thinking of a guy, Dr. Henry Malley, and Dr. Isaac Slaughter. Dr. Henry Malley was one of my mentors, who was just the salt of the earth. He was a doctor's doctor, I have to say. And I have to say that I want to publicly thank those physicians, Dr. Slaughter, Dr. Malley, for giving me a chance, for allowing a young African American man to go down to West Oakland Health Channel along with a young guy named uh, Dr. Staggers Jr. Uh, Dr. Staggers Sr., again, Herculean figure, physician, urologist, uh, and he birthed a son who I had the pleasure of working with over a number of years. And maybe I'll talk about that one day, but for now, yeah. Um, I think that too. Um, we find a lot of the African American providers have lost the joy of medicine. They no longer want to practice. I've had recently talked to 5 physicians that have retired. Just, I mean, all that knowledge just lost because they no longer want to practice. We have to do something about that. And we understand that too, that 75% of the practice of the medical practice are controlled by medical groups. Only 25% are private, and of course they're struggling after the pandemic. All this stuff, it costs more to do what they're doing. Again, inflation is that. What's inflation? Cost me more to provide that service that I gave you 5 years ago for this price. Rent's gone up. Medicines have gone up. Everything's gone up. Again, nobody's fault. It's not a blame. It's just that's the way it is when you reopen from a pandemic. I don't understand what people thought that things were going to be cheaper. And but what we should understand that, it's nothing against anyone, is that, you can't have supply chains with your enemies and expect them to respond to you in a matter after you talk bad to them, talk down to them, and then this definitely is Russia, definitely China. Look at, just go in your house, look at everything that says made in China. A lot of its stuff is. A lot of our stuff is. Anyway, that's another discussion. And like I said, COVID's not over yet. I There was an initial CDC webinar in 2021, and it reported that 40% of U.S. adults were struggling with mental health or substance abuse post COVID. 31% anxiety and depression, trauma related issues with 26%, started to use more substances, 13%, seriously considered suicide, 11% blacks and Hispanics, increased suicide ideation by young and poor, and with poor mental health, and increased depression among younger and minority. I think that's something that we need to kind of understand. Again, that national suicide number for the CC is 800-273-8255. It's a national hotline. Again, if you're feeling that you want to hurt yourself or harm yourself, please get to your provider. Please get to the ER. Don't do it, please. Um, um, and Call a family member or friend. Always important. And I wanted to also talk about. First of all, I want to thank everyone for listening and allowing me to express some of the things that I think are really important that I'm not hearing, that I want to shine a light on. It's always important that we try to, you know, um, have as best we can um, um, a full view of the things that are going on. Um, I was reviewing some articles, this article called MedLinks, and yeah, it brought some things I thought were really kind of interesting. It's kind of like as we close the show out, I thought this was really interesting. This is the feature article was teaching critical race theory in medical school could improve patient outcomes, and it said that again, this is an article by Jules Murith, and it was fact checked by Barbara Brisk, and it was published on May 20th, 2022. Again, this is MedLinks. This is kind of a physician provider related forum for keeping up to date and staying current. And so it says that up to 40% of white medical trainees believe that black people have thicker skin, are less sensitive to pain, and that white people, which can lead less than white people, which can lead to less than optimal care for pain management in patients. And we know that to be true, that even though in this opiate epidemic and overdose, we in communities of color have always been undertreated, particularly in areas of pain. And so this discussion around they define critical race theory. It teaches students that race is a social construct ingrained in the fabric of society, institutions, and structures rather than force perpetuated by individuals. The implementation of critical race theory in medical schools could help trainee physicians break down racial stereotypes instead of focus on the experiences and knowledge of patients of color to mitigate race-based disparities. And I think that something like this needs to start happening, and definitely from an education perspective, because if you if your discussions and information and thought process about an individual aren't science and evidence based, then they get into the issue around, believing some very bizarre things. And I don't think this is Article 4 or against critical race theory. It's saying that we need to open up to uh, a different level of education and understanding what these things mean. And I think that we have to stop being narrow. And that's why I want to understand white replacement theory, because maybe it's valid, but from my understanding of it, it doesn't look it doesn't carry enough weight. Um, and so uh, they talked about that achieving health equity hinges on the dismantlement of forces such as racial injustice, which unfortunately shows up in medical spaces regularly. So now we're starting to get into discussions that 30 years ago, when I had these discussions, now, man, it was hard to keep a job because, as I was told, um, you focus too much on race. Well, that's the community I was taking care of. Africans Americans, particularly those related to those living in the late 1619 or 14th Amendment, which freed us. Um, one of my good friends, Carolyn, reminded me of that today, so I want to thank her for that. Um, and it says that racial, and this is back to racial disparities also surface in death and disease process due to COVID. Some racial groups have faced barriers in obtaining access to COVID vaccines. To change racism impact on racism with the healthcare system, physician intervention, just not recognition is necessary, and also a belief that the vaccines work. So we have a group of folks in medicine, has a bit of a group of community that don't believe the vaccine work and should be used. And so, where's the science? Where are the ethics? Even if you didn't believe it, if it would help someone get from getting sick or having injury or morbidity, sickness, mortality, death, then why wouldn't you want to do that? Well, it tells a lot. And the discussion is we want to treat all patients equitably, so and the take home message in this particular article, which I thought was really interesting, says trainee physicians aren't immune to racist ideologies and could harm their patients down the line. Mistaken beliefs such as blacks have more pain tolerance than others can lead to inappropriate treatment. To combat disparities, uh, which should often rise as a result of systemic racism in medical schools, can implement CRT, critical race theory. Trainees should learn to dismantle racial stereotypes and avoid defaulting to race as a de facto explanation for observed inequities. Physicians can also go beyond recognition alone and can action and can physicians who can go beyond recognition alone can take action to address racism as a barrier to inequality. Oh, and to quality medicine. My point. Um, I think that um, uh, we are at a point where this should be what we're doing as opposed to what we're not doing. Um, and uh, again, this is where we have to have more education and more knowledge. Um, and we have to be fair. Um, and I want to mention um, that one of the systems of fairness I think should be involved is that we have a African American steering committee for health and wellness, and the committee is comprised of community and stakeholders and the matter experts for Black community in Alameda County. It's broad based, and then it's African American members representing consumers, families, providers, clergy, systems partners. And the goal of this was to ensure new programs and infrastructure are developed with input from African American subject matter experts, recommendations to the African American Steering Committee for Health and Wellness. So now this utilization report has been since 2011. Well, why no action on it? Well, the discussion around a system of healthcare that looks at us and puts us at the center has always been a bone of contention, not only in the society, but also not only in its local communities, but the society. And again, the discussion of um, a and a lot of the studies show a medical home and are dynamic for folks of color in terms of having mental health and uh, a medical component in the same vicinity, so the two can work with one another, and so it creates an incentive to get the care because it's localized. Uh, I thought something was interesting, and I'm going to close the show out with it. And I said COVID was really um, changing lives. And I'm going to report. I'm going to respond this to a Harvard health blog, and it's a intimacy, sex, and COVID-19. And this is by Hamad Farad, MD, and it was April 15, 2020. That was written, and so, uh, and the discussion was uh, how COVID had changed relationships and intimacy, and I thought it was kind of interesting. And so it asked the question, where it goes over the, again, how is COVID spread? COVID is spread by respiratory droplets through sneezing, coughing, and nearby droplets land on people's mouths and noses, and how people inhale them and get infected. The viral particle kind of as an aerosol. That's why it sits in the air, and that's why it's important to wear masks. And people may inhale those aerosols and get infected. It can live on surfaces. Why this big issue with the cleaning and here was, I thought was interesting. It says the virus may be shed in saliva, semen, feces, and whether is shed in vaginal fluids isn't really known. Kissing can transmit the virus. You obviously would be very close contact with the infected person. Transmission of the virus through feces or during vaginal or anal intercourse or oral sex appears to be extremely unlikely at this time. So that got me into thinking about, well, what are folks doing? And of course, it asks the same question: how safe is intimacy with a partner? And the CDC still recommends 6 feet separation, and the discussions of um, uh, it still doesn't mean you should isolate. You should have to isolate yourself from your partner. Still doesn't mean that you should isolate yourself from your partner. It's in fact says if both of you are healthy and feeling well and participating in social distancing, have had no known exposure to anyone with COVID, touching, hugging, kissing, and sex is more likely to be safe between your partner. Uh, um, and so what they say also says if you or your partner have been sick with COVID and now experiencing recovering, is a couple ways. CDC page explains the ways to prevent the spread of germs, including not sharing bedding or presuming in bed, abstaining from intimate social contact until at least 7 days after the symptoms have started, and other symptoms have improved, and at least 72 hours of fever free without the use of any medications. Again, you have to talk to your provider about these things, but it sounds like one study said that you should at least have 14 days to minimize your contact. Um, Always interesting. How has COVID changed our lives? How COVID changed COVID? How we changed things? I always, well, what have you been doing? And how have you doing? Have you been intimate? Have you not been intimate? There was one story where two physicians, one lived on the top floor, one lived on the bottom floor. I thought it was really kind of interesting. And it says that um, the good news that says that they found that there was a 14.9 transmission rate among household contact. Risk to household members are minimized through steps that include self quarantine for the person showing signs of illness and excellent hand hygiene in the whole household. So, well, welcome to the new normal. Um, and uh, that's kind of some of the things that Asta says about what if your partner works in a job where there's a high risk of catching the virus? If your partner works in a high risk field such as healthcare or has contact with the general public, decisions around intimacy or even self quarantine in the absence of symptoms are personal. Some health workers have quarantined themselves with other families, while others practice good hygiene and have separate set of clothing dedicated for work. And you and the partnership you can discuss what are both comfortable with. It. Well, for me, I was coming into the house, taking off my clothes. Always having a different set of clothes for every day. And when it first hit, because you didn't know what it was. Yeah, people that may be immune compromised. Again, I get back to we should be trying to protect the babies in this. That 0 to 4 is who I'm concerned about. Um, Again, I want to thank all you for taking the time to listen. Uh, and as a final note, it says, are there any forms of intimacy and sex completely safe right now? 6 feet of separation required by social distancing may not entirely slow you down. There's always faced forms like masturbation, phone sex, and sex toys. Uh, and I guess imagination may play a big role in this too. Um, and your mood and that kind of thing. I think that although this pandemic may have dampened desire and all those kind of things, hey, you have to still protect yourself, be safe, and you know, maybe conversation, right? You have to talk these things out. Uh, there's not be a right or wrong way for anybody or everybody. Um, I I want to say also again I emphasize that the uh, uh, COVID is not going away. I want people to kind of stay with that mindset throughout as we move throughout this summer months and we're trying to return to normal. Just be safe. Um, I think I'm going to end this with a discussion around from the Declaration of Armada, and it says uh, that the this conference strongly affirms that health, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, is a fundamental human right, and the attainment of the highest possible level of health is the most important worldwide social goal, whose realization requires the action of many social and economic sectors in addition to the health sector. Again, back then in 1978, we knew that health is a multitude of factors. I think that my training has always spoke to that. And again, I want to thank those mentors, Dr. Slaughter. And uh, I understand that PT Pathways of Wellness is doing an event today. I hope they're having a great time and being safe and enjoying themselves. I want to thank Carol of Conscious Voices. She gave me a T-shirt today. I love it. And again, I think that we do ourselves fine. It's a it's always an ongoing discussion. I know. Let's learn and grow together. Let's be nice. You know. Um, and finally, again, one who has become one of my great mentors, uh, uh, OG Mandingo, and in his book, his Taught the God Memorandum, He states, count your blessings. Please don't forget, just count your blessings. Proclaim your rarity. Go the extra mile and then go another extra mile. Use wisely your power of choice and to do all things in love. I think that bears repeating. Count your blessings. Proclaim your rarity because there's no one like you. No one. Go the extra mile. And I would say when you go the extra mile, even if you have to serve an ungrateful master, serve him better because what is due you is already going to be paid back in full. Uh, use wisely your power of choice as a human being, as a person, for humankind. I give women that power of choice over their bodies, and we didn't get a chance to talk about the anti-abortion issue, but I believe women should have a power of choice and do all things in love. And even if you disagree with somebody or you don't get along with somebody, don't stop loving. You know. Again, I want to thank you for taking time to talk with me, to share this, to share the time here. It's gone already. My goodness, I was like, man, I'm just doing it. You know, Miss Howard will be back next week to spin her magic. And I want to thank you folks for listening to Me and Believe Radio. It's a 24-hour inspirational gospel. Uh, uh, let's like this Facebook up. Let's like the likes up and the looks up. We want this to be an ongoing conversation about how we get better as a community, as a group of folks. Uh, I want to thank your time. We are blessed. You are loved. Um, uh, be safe out there, I just am excited to be at this point, at this time and place, speaking to everyone involved. Have a great, 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 great week, month, year. Good night.